I'm Gordon Earl at Albert Einstein College of Medicine. Thanks for joining us. On this segment of Einstein On, we're discussing some of the latest research in cancer. We're also discussing what's going on at the Montefiore Einstein Center for Cancer Care. Joining us today is the director of the center, Dr. Stephen Libutti. He is an internationally recognized endocrine surgeon who came to Einstein from the National Cancer Institute. Dr. Libutti, thank you for joining us.
It's my pleasure.
Let's start at the beginning. I read that you first became interested in medicine as a child watching Marcus Welby and MASH. Is that true?
Yeah, it is true. Hopefully it doesn't paint the picture that all I did during my childhood was watch television, because that certainly wasn't the case. But I found those stories for different reasons very inspiring as a kid, especially with respect to MASH and seeing although obviously a lot of the storylines were focused around comedy, the situation was very serious, and I think it made a big impression on me growing up.
Now we'll stick with your childhood for one more question. I read that you dreamed of becoming the team doctor for the Yankees and the Giants.
Yeah, so I was very interested in sports growing up and thought my future was going to be in orthopedics or sports medicine. And I was very interested in the Yankees. I remember both with respect to the Yankees and the Giants, my dad taking me to games when I was little. And I dreamed that someday I'd be able to go to all of the games as the team doctor. But once I got into medical school, it became clear to me that my interests were going in a different direction.
Okay, let's fast forward to more recent times. Before coming to Einstein, you were at the National Cancer Institute. Tell me about your work there.
Well, I arrived at the National Cancer Institute in 1995 with the initial intent of staying for 2 years. And I wound up staying there actually for nearly 14. It was an incredibly exciting place to work, and it gave me a lot of opportunities to explore very interesting research questions, many of which focused on tumor angiogenesis and the tumor microenvironment. I also was very involved in applications of regional therapy for cancer. And what I mean by that is the ability to deliver high-intensity chemotherapy and biologic therapy to organs or regions of the body where the tumor was present to try to minimize systemic toxicity from those therapies and maximize efficacy from those therapies. And so my time at the National Cancer Institute really gave me the opportunity to explore how we can strike a better balance between efficacy and toxicity, and really, for me, gave me the opportunity to ask some what I think were novel questions about new ways that we could target or deliver therapies to the tumor outside of having to actually use a surgical procedure or tourniquets to isolate the therapies we were delivering to those regions of the body where the tumors existed.
What were some of the questions you were asking?
So the way we went about delivering regional therapy back then was through surgical procedures. And these are still done today to a large degree. But for example, the liver can be the sole or dominant site for metastatic cancers such as colon cancer and ocular melanoma. Also, neuroendocrine tumors tend to have a predilection for metastasizing to the liver. And often patients won't have disease in other locations, and that burden of tumor in the liver can be life-limiting. So one of the strategies we explored at the National Cancer Institute during the mid-90s into the early 2000s was to take patients to the operating room and perform what was called an isolated hepatic perfusion. This was a very involved operation. It could take anywhere from 5 to 8 hours to perform. We isolated the blood vessels that went into and out of the liver and basically attached the liver to a heart-lung machine and gave very high-intensity chemotherapy and biologic therapy along with heat to the liver to treat the tumors present. And the idea there was if we could isolate the therapy to the liver, we could minimize systemic toxicity and maximize therapeutic activity to the area where the tumors were present. That worked very well, but the problem was we could only give the therapy once. And if a patient wasn't cured, quote unquote, of their tumors, that is, all their tumors disappeared, we knew they would eventually grow back. And so the challenge was, how do you deliver that same sort of targeted, effective therapy to tumors without the need to apply a major surgical procedure to do it? And it's that question that I spent the rest of my time at the NCI focusing on, and part of what I've brought to my work at Einstein.
Which leads us to the question of why you came to Einstein.
So it's interesting. Sometimes things are planned in your career or in your life, and then other times things have a habit or of forces colliding. And for me, with respect to coming to Einstein, it was a combination of both. I had the privilege and opportunity while I was at the National Institutes of Health to work with an investigator at the National Institute for Diabetes, Digestive, and Kidney Diseases, Dr. Alan Spiegel, who is now the dean at Einstein. And Dr. Spiegel and I were both interested in a familial tumor syndrome called MEN1, or multiple endocrine neoplasia type 1. These patients develop tumors of their pituitary glands, their parathyroid glands, and their pancreas. And we were caring for these patients at the NIH, and we began to ask questions: what is it that leads to this tumor formation in these patients? And at the time, Dr. Spiegel was working with Dr. Francis Collins, who's now the NIH director, and a team of scientists, and they had recently cloned the gene for MEN1. And Dr. Spiegel approached me about collaborating with him on developing mouse models for the MEN1 syndrome. And our strategy was to develop model systems where we could selectively remove the gene for MEN1 in tissues at risk in mice, like the pancreas and the parathyroids, and then determine if those mice developed the same tumors we saw in patients. And we did. We worked on that project together, generated those mice, and lo and behold, they did generate very similar tumors that we see in patients. And that strategy of trying to understand those tumors and how MEN1 works as a tumor-regulating gene is still the subject of much of my work at Einstein. So I was very impressed with Dr. Spiegel. He was a great collaborator and colleague, and so when he moved to Einstein, it put Einstein on the map for me as a place where exciting things were happening. The second was while I was a resident at Columbia Presbyterian Hospital in the early 90s, I worked with a fellow in cardiothoracic surgery named Robert Michler, who is now the chairman of surgery and the chairman of cardiovascular and thoracic surgery at Montefiore Medical Center and Einstein College of Medicine. And Rob and I were good friends then, and he, as he is now, was an impressive figure then, and I enjoyed working with him and having him arrive at Montefiore and Einstein and Alan Spiegel arrive at Montefiore and Einstein. It was sort of, you have to read the tea leaves sometimes.
It was a perfect storm.
Yeah, it was a perfect storm. And the opportunities available at both Albert Einstein College of Medicine and Montefiore Medical Center to perform cutting-edge scientific research in the laboratory. I mean, we have some of the greatest programs in genetics and genomics, diabetes research, cancer research, heart disease here at Einstein. And Montefiore's unique patient population and the commitment of the medical center to provide outstanding care to the immediate population of the Bronx and beyond, to be a destination center, together with my past relationships with Dr. Spiegel and Dr. Michler, seemed to me to be too many things aligning not to look into a change, a move.
How would you describe the primary mission? I know there are a lot of things that you're doing, but the primary mission of the Montefiore Einstein Center for Cancer Care.
For me, the principal mission of MECCC is to deliver a level of care to the patients in the Bronx, as well as patients from outside our area, that combines the best that new scientific findings have to offer, new therapies, cutting-edge clinical trials, but in a caring and compassionate way that lowers the barriers for patients and their family to access cancer care. And what I mean by that specifically is one of the hardest diagnoses to be given as a patient or a family member is a diagnosis of cancer. It not only affects the patient, but it affects every member of the family, because that patient is often a major caregiver or a major figure in their own family circle. And when folks hear the diagnosis of cancer, they often think that they're helpless or there's nothing they can do. They don't understand what the steps are in their care. They don't know where to start. It can be very challenging for them to navigate from one specialist to the next in terms of taking all the information and even physically going from one place to the next to be seen and to get the best opinions they can and to synthesize all that together. And what we hope to do at the Montefiore Einstein Center for Cancer Care is to take a lot of those burdens off the patient, to bring multidisciplinary care teams of experts in surgical oncology, medical oncology, radiation oncology, gastroenterology, pathology, radiology, etc., all under one roof, working together in disease-specific programs focusing on diseases such as breast cancer, or colon cancer, or lung cancer, and seeing the patient in one place in a common period of time. So there's literally one-stop shopping for the patient to be able to see all of their health providers in the cancer space in one facility that makes available to them the best we have to offer in clinical trials and outstanding practitioners to deliver the best possible standards of care.
In a press release, when it said you were coming to Einstein, it mentions the word, quote, transform the way we deliver care to cancer patients. This is what it sounds like you're talking about, with a touch of empathy.
And I think that's critical. I think we don't have the cure for cancer at the moment. We can certainly cure some cancers if we catch them at an early stage, and even for some cancers at advanced stage. With appropriately applied multimodality therapies, we have some very exciting results. Patients can live 5, 10, 15 years to what we consider cures in many situations, but we certainly can't do that for the majority of patients with advanced stage cancers. And so it's critical that we care for them in addition to attempting to cure them. And what I mean by that is understanding what they're going through, empathizing with their situation, and trying to deliver their treatments in an environment that cares for them beyond just treats them.
Describe to me what some of the novel treatments are that you're looking at, because I understand, again, from reading some material that you are looking at some novel treatments. Give an example or two.
Certainly. So, as I had mentioned earlier, one of my principal focuses while I was at the National Cancer Institute was mitigating this balance between efficacy and toxicity and delivering therapy that is regionalized. It goes after where the tumors are, but tries not to adversely impact on the patient as a whole. And so some of those therapies I'm hoping to bring, and in some cases have already brought, to our efforts in cancer care at Einstein and Montefiore. For example, while at the National Cancer Institute, we conducted trials utilizing a way of delivering intense energy to tumors to kill the tumor cells called radiofrequency ablation. And this can be used to treat tumors in the liver. That's available at many centers now, but what we did there that was novel was married that therapy with a heat-activated liposome that carries a chemotherapeutic agent, and when heated beyond a certain temperature, releases that chemotherapy in a high concentration where the heat was delivered. So we can deliver this heat-activated liposome systemically, give an intravenous injection of it, but it'll only be activated where we apply our radiofrequency ablation to the tumors in the liver. And I conducted the phase 1 clinical trial for that while I was at the NCI, and we now have plans to conduct the phase 2 clinical trials here at Montefiore and Einstein. Another example is nanomedicine. So while I was at the NCI, we were very interested in developing nano platforms, small particles that could carry anti-tumor agents selectively to the tumor bed, again, trying to lower toxicity and maximize therapy. And we conducted a phase 1 clinical trial of a nanomedicine, a gold particle that carried tumor necrosis factor, which prior to that could not be given systemically at safe doses because the doses that treat tumors were much higher than the doses that cause toxicity. But when we connected or linked that tumor necrosis factor to gold nanoparticles, we found we could give high enough doses to reach the therapeutic doses and mitigated much of the toxicity because of the trafficking of those particles to the tumor environment. And now, having completed that phase 1 study, we're hopeful of beginning phase 2 studies here at Montefiore and Einstein to study that strategy.
Now, you've just mentioned 2 clinical studies. Are there any other clinical studies in the works right now?
Well, we are members of a number of cooperative oncology groups. The Eastern Cooperative Oncology Group is a very big group that brings together medical centers across the country to study a variety of novel approaches to treating a variety of cancers. We're very fortunate here at Einstein and Montefiore to have Dr. Joe Sperano, who is an expert in breast cancer, who leads the breast cancer group for ECOG, so we avidly participate in those trials. Also in breast cancer, we were very fortunate to recruit Dr. Leslie Montgomery from the Memorial Sloan Kettering Cancer Center, who is an expert in breast cancer surgery and breast cancer trials. And we are now members of the American College of Surgeons Oncology Group, which is another cooperative group that conducts clinical trials research. And Dr. Montgomery is the principal investigator for breast cancer trials with ACOSOG. We have very talented investigators throughout Einstein and Montefiore, and I'm fortunate to work with many of them in the Montefiore Einstein Center for Cancer Care. Among them, Dr. Chandan Guha, who is very focused on marrying radiation therapy to modulation of the immune system. And much of his work in looking for immune stimulators to try to generate an immune response against cancer and marry that to radiation therapy are very exciting avenues for us to pursue, and there are a number of clinical trials that he's working on. So I think the future within both Einstein and Montefiore with respect to cancer research and cancer care delivery is very bright, combining the outstanding excellence that already existed here with a number of new faculty that we've recruited and with some new initiatives that we're bringing.
Is there any, in terms of your own research that you're doing, not those of your colleagues, but your own research, is there any other area you'd like to mention as a part of your own investigation?
Well, my lab is interested mainly in 3 broad areas of investigation. I spoke briefly about one, which is developing model systems for studying cancers. And my interest as a surgical oncologist and endocrine surgeon focuses on endocrine tumors, tumors of the pancreas, tumors of the thyroid, tumors of the adrenal, tumors of the parathyroid. And we've developed model systems in the laboratory where we are able to delete genes such as MEN1 and follow the development of tumors in animal models and then learn perhaps what it is about the removal of the activity of that gene that leads to tumor formation. And this could potentially identify for us targets of therapy for patients with tumors like the ones we see in the model system. So that's one major area of investigation. And another is on these targeted therapies. And one of the areas that I'm very excited about in the lab right now is through a collaboration with MD Anderson Cancer Center and investigators there, Dr. Renata Pasqualini and Dr. Wadi Arap, we have developed a targeted gene therapy platform that is based on bacteriophage. And these are bacterial viruses that don't infect human cells very well, but they can infect bacteria very well. And we've altered them to be able to selectively infect the cells of the vasculature in tumors and express at a high level proteins that will destroy both the tumor vasculature and the tumor cells themselves. And we think that that work is very promising. We've conducted both small and large animal studies with this platform, and we're nearing the time where we think we'll be able to launch this into a first-in-human clinical trial. And my hope is to bring that first-in-human clinical trial to Einstein and Montefiore. The final area is in basic biology of cancers and endothelial cells, and we're very interested in invasion and metastasis. And we have identified a protein we think plays an important role in ovarian cancer invasion and metastasis, and working very closely with Dr. Gary Goldberg in the Division of Gynecologic Oncology, we have begun to study the role of this protein in ovarian cancer.
I saw you give a presentation recently, and there was a very interesting slide. I think I've interpreted correctly. It says that for people under 85, there's now the incidence of cancer deaths was greater than the incidence of heart deaths, if I got that correctly. Is that true, and why?
So the article you're referring to that I quoted in that presentation is from the Cancer Journal for Clinicians, and the article is based on American Cancer Society statistics and data. And what it showed is beginning around 2001 to 2003, if you look at the number of deaths per 100,000 population in the United States, and you look at deaths due to heart disease, this is heart disease itself, not necessarily cardiovascular disease, which includes strokes, but heart disease without strokes included. For patients under the age of 85, the death rate due to cancer has eclipsed the death rate due to heart disease, and that's what that graph was. And so what that means to me is not that we're losing the war on cancer, but the progress being made in mitigating death due to cardiovascular disease is at a more rapid pace than the progress we're making in cancer. Now, we're certainly making progress. Another slide I could have shown from that same publication demonstrates that the rate of cancer deaths has leveled off to some degree, or at least that slope is coming way down. And if you look at what we predicted the number of cancer deaths to be in 2010 to what the actual number of deaths are, and you look at combining men and women over a 10-year period, we've reduced the total number of predicted cancer deaths by a significant amount. But we're still not at the goal line I think most of us in the field would like to be, where we have as fast a downward slope in death rate due to cancer as we're starting to see in heart disease.
Let's look at the next 5 to 10 years. Bring out your crystal ball. What kind of improvement can we see in terms of effective therapy that not only attacks tumors but also attacks the spread of cancer throughout the body? What does it look like down the road? You've used the word promise in terms of some of your therapies. What kind of promise do we have?
So I think there are two areas that we need to focus on over the next 5 to 10 years. The first is the power we have now to study the genetics of cancer far outstrips what we could have even imagined even 15 years ago. The sequencing of the human genome, and now as we begin to sequence common cancers, are going to really reveal to us a blueprint of the machinery that goes into cancer development, progression, invasion, metastases, etc. And the ability to look at differences between aggressive behaving tumors and less aggressive behaving tumors and normal tissue counterparts, I think are going to start to give us some insight into how cancers work and what we can target with future therapies, again, to try to maximize efficacy and minimize toxicity. That's one half of the equation. The other is really recognizing what causes cancer, the risk factors. And if we can begin to seriously mitigate those risks through screening programs, for example, the observation that colon polyps move on to colon cancers, and applying colonoscopy, whether it be a fiber optic colonoscopy or virtual colonoscopy to screen the colon in patients, has, I believe, contributed to the decreased incidence and death due to colon cancer that we've seen over the last 10 years. If we can expand those sorts of programs to lung cancer, for example, to breast cancer, to other common tumors, that also will help us make progress in decreasing both incidence and death. And so some of the novel science that's occurring at Einstein, work by Simon Spivak, looking at exhaled breath and looking for markers of lung cancer or determining lung cancer risk, I think will be very promising along those ends. Work done in the genomics facility under the leadership of Jan Vij, looking at ways that we can leverage various genomics platforms to better understand how tumors work, I think are going to enable us to make progress on both those fronts.
Is it fair to describe yourself as an optimist?
I think I am. I think it certainly beats the alternative. So I think that if folks are willing to work together and are focused on a goal, and they apply their energies and intellect to it, virtually anything can be accomplished. And so I like to go through my days thinking that what we can do rather than thinking about what we can't do. And I think that Montefiore and Einstein are both poised now to do a lot of things together, and I think we can accomplish a great deal.
Well, on that optimistic note, and with you smiling, we thank you for joining us.
Thank you.